Good evening, everyone. My name is Dan McCartney, and tonight I'm going to be presenting on behalf of the Covid-D Consortium, describing the evidence linking low vitamin D status with increased risk and severity of COVID-19. Now, before this pandemic ever arose, we already knew that people with low vitamin D status were more likely to suffer from acute respiratory infection. And we also knew that people who supplemented daily with vitamin D seemed to be protected against these acute respiratory infections. From very early in the pandemic as well, we recognized that those groups who were most severely affected by COVID-19 were the very same groups that were most likely to be vitamin D deficient. Again, from early in the pandemic, we recognized that people severely affected by COVID-19 had a particular immunophenotype that had significant overlap with that which you would expect to see in severe vitamin D deficiency, with these very high levels of inflammatory cytokines and this aggressive Th1 adaptive immune response that's characterized by the cytokine storm. So before we had any direct evidence linking vitamin D levels to COVID-19, we had a lot of evidence to suggest that such an association might exist. Declan and I published this last April in the Irish Medical Journal. In this article, we suggested that vitamin D or low vitamin D status was a causal effector of increased risk for SARS-CoV-2 infection and also for more severe outcomes from COVID-19. We also suggested that the Irish adult population should be supplemented with vitamin D at levels higher than those currently recommended to mitigate these risks. Professor Roseanne Kenny's group were working on the same premise at the same time and published this report the same day, coming to some of the same conclusions that we did, and also coming out strongly in support of higher level supplementation to mitigate these COVID-19 risks in older Irish adults. Around that time, we began to see some geographic studies which showed us very clearly that COVID-19 incidence and mortality increased the further you went away from the equator, and also that these were higher in countries with confirmed low vitamin D status. The last of these studies is an interesting one, which shows that the surge in COVID-19 incidence, which occurred last autumn and winter, coincided in these different individual countries almost exactly with the day on which those countries dipped below 34% of the UVB exposure experienced at the equator. We did begin to see direct evidence emerge from about May time onwards, showing us much lower vitamin D levels in patients that had SARS-CoV-2 positive results. So this first one from Switzerland, for example, showed us that SARS-CoV-2 positive patients had an average vitamin D level of about 27 nanomoles per liter versus 61 nanomoles per liter in those who tested negative. The Meltzer study from Chicago showed a 77% increased risk of SARS-CoV-2 infection in those who were vitamin D deficient. And then the final study by Kaufman showed a doubling of SARS-CoV-2 infection risk in those with levels less than 50 nanomoles per liter versus those who achieved levels more than 137 nanomoles per liter. We also saw observational clinical studies from hospitals. Frank Lau's work, for example, in Louisiana, showed average vitamin D levels of about 48 nanomoles per liter in very sick patients admitted to ICU versus 75 nanomoles per liter in less sick patients that remained in the wards. Professor Fall's work in Blanchardstown showed a more than threefold increased risk of requirement for ICU admission in patients that had low vitamin D levels. And then this other study by Radakovich, colleagues in Germany, showed a six-fold increased risk for invasive mechanical ventilation and a 14 to 15 times increased risk of death in patients with vitamin D levels less than 30 nanomoles per liter. But of course, these are associative data. They don't necessarily infer causality. However, the intervention studies soon followed. The best known of these is from Castillo and colleagues in Cordoba, Spain, where they took 76 COVID-19 admissions and gave 50 of them vitamin D, and 26 of them didn't receive any. Of the 50 people who got vitamin D, just 1 or 2% ended up in ICU. Of the 26 who didn't get vitamin D, 13 ended up in ICU, and 2 of them unfortunately died. So this equates statistically to a 30 to 35-fold reduced risk of ICU admission in patients given the activated vitamin D. The Anweiler study in France showed about half the mortality rate in older nursing home residents who were given vitamin D in high bolus doses during their admission for COVID-19. And then the UK studies showed much lower odds of mortality for people given bolus vitamin D doses during their admission. Next slide just shows what happened in Andalusia, Spain. They started to supplement vulnerable older adults with activated vitamin D from about mid-November onwards there. And you can see that their death rates went from about 70 per day in mid-November right down to 3 per day at the start of January. And those data are all the more striking given the explosion in incidence and mortality that was occurring all over the rest of Europe at the same time. This following slide is a repository where you can view the various studies that are being published in relation to COVID-19 and vitamin D over the coming period. It's called the C19 vitamindi.com website. So all of the studies that are published in this area get curated there. We do have some meta-analyses. This first meta-analysis is, as you can see, 10 studies, more than 350,000 patients, and relates to SARS-CoV-2 positivity. So you can see there an odds ratio of about 1.5 times the likelihood for people that have vitamin D levels less than 73 nanomoles per liter. This following meta-analysis is of intervention studies in the area, 4 of which were deemed to be of sufficient quality to be included. And again, you can see much lower mortality rates here in the vitamin D intervention groups who received supplementation than in the controls. We also have laboratory studies which show us some of the mechanisms by which vitamin D may be mediating these effects. For example, the first of these studies listed here showed a direct inhibitory effect of vitamin D on SARS-CoV-2 viral replication in cultured human nasal epithelial cells in vitro. And the second study explains some of the molecular mechanisms by which those effects might be mediated. So we published all of this in November. This is our diagram explaining the mechanisms by which vitamin D mediates its positive effects on outcome. So moderation, for example, of the renin-angiotensin system and the kinin-kallikrein system, and then direct positive effects on both innate and adaptive immunity. I know that there are many that would call for randomized placebo-controlled trials in this area to assert with definitive certainty that vitamin D supplementation can be beneficial. It's unlikely that we are going to see those data anytime soon. However, the data that do exist at the moment meet the Bradford-Hill criteria for causality, which have been used to underpin other very successful public health interventions, such as the workplace smoking ban over recent years. So we can return to that in the questions perhaps later. What's the scale of this problem? Well, vitamin D deficiency is really, really prevalent in Ireland, not just in our older population, but also in our younger adults, about half of whom have low vitamin D levels when tested. There are, however, much higher levels of vitamin D deficiency in our nursing home residents and in people with darker skin living in Ireland. We also know that vitamin D supplementation is safe. For example, EFSA, the IOM, and SACN are all in agreement that oral intakes of less than 100 micrograms per day do not cause toxicity. So while you need to be careful with some limited number of clinical conditions, and you can see them listed here, it is perfectly safe for adults in Ireland to supplement with 20 to 25 micrograms per day to get them above the 50 nanomole per liter threshold at which immunity is enhanced. This again is our position statement. So our recommendations from that were that adults should supplement with 20 to 25 micrograms per day, and that for adults that have a greater likelihood of severe deficiency, older people, people in nursing homes, those with darker skin, or who are overweight or obese, they will need higher doses, but those should be given under medical supervision. We also think that co-supplementation with magnesium is a good idea here, as it activates vitamin B in the body. Just to finish with a bit of context, we're dealing here with a global lethal pandemic that's cost more than 4,000 lives in Ireland over the last 8 to 10 months. And about half of these case fatalities were in nursing homes with people who are highly vulnerable to vitamin D deficiency. So in that context, we have nothing to lose and everything to gain by initiating population supplementation at these appropriate doses. I'll just finish by thanking my colleagues in the Covit-D Consortium. It's been a great pleasure and privilege to work with them in this project over the last number of months, and also my colleagues in TU Dublin and Trinity College, INDI, and Frazinas Cabby, and just wishing well to the other presenters and nominees tonight. I'll leave you with this comment from Mike Ryan from WHO, and I'm happy to take any questions. Thank you.